Okay, good afternoon, everybody. My name is Dana Beaver Lewis, and I would like to welcome you to our webinar, Social Determinants of Health, Where Do Case Managers Start? We're very excited about this presentation because not only are we going to talk about SDOH, but we're also going to identify some low-hanging fruit that would help us include SDOH in our daily workflow. So before we get started, I want to mention a couple of housekeeping items. If you would like to ask a question, if you could just document that in the chat bottom right-hand side, and then we will read that during our question and answer session at the end. Also, we'll be including a quick poll that we would like everyone to participate in because we're really curious as to how people are identifying their SDOH patients right now. So presenting today will be Beth Brand, our VP of Product and Customer Solutions, and yours truly, Dana Beaver Lewis. I am one of the senior clinical product consultants here at MoreCare. So without giving away our ages, between the two of us, we have over 60 years of hospital experience. So you are in good hands. No worries, Beth.
Wow.
So Beth,
Thank-
go ahead.
Wow. Thanks so much, Dana.
Uh-huh.
And thank you to all of our attendees today for spending time with us this afternoon. We appreciate that. I think that we can all agree that the subject of social determinants of health is fascinating and yet overwhelming at the same time. The good news is that we're at a point in time where health systems, providers, and payers are all recognizing the importance of this. And there really is a desire to figure out how to incorporate SDOH stressors into the care that we provide to patients. Today, Dana and I will be sharing some thoughts on how care managers can incorporate this important information into their workflows, and by doing so, how they can improve outcomes and decrease the cost of care. In today's session, we will be looking at vulnerable patients, those patients with SDOH risks that are jeopardizing their health outcomes and are also increasing the cost of care. We're going to talk about how to utilize patients assessment, and we will actually present some options and discuss how these can provide benefits. We're going to look at how you can begin to connect to and source community providers. And we're also going to talk about some recommended patient engagement strategies. We are going to have a demo where Dana is going to walk us through how some of the MoreCare solutions support these efforts. And of course, we would love to have questions and answers from you all at the end of the presentation. So please hang on for that. Well, let's start with social determinants of health. What exactly are these? It's like the latest buzzword in healthcare, and yet sometimes people really struggle to understand what these are. The World Health Organization defines these as the conditions in which people are born, grow, live, work, and age. These really are the forces and the systems that shape the conditions of everyone's daily life. We know that they affect nearly everyone, and they play such a key role in the long term health and outcomes of our patients. And indeed, it is believed that these have the biggest influence on an individual's health status, more even than the clinical care that patients receive. And as a result, healthcare organizations are feeling the pressure to extend their reach beyond the confines of the hospital campus and connect with patients where they live, in their communities, at their workplaces, and at their schools. This is a quote from the president and CEO of the Robert Wood Johnson Barnabas Health System. And it's his belief that what defines our health is so much greater than genetics or clinical care. He says that 80% of all health outcomes are due to social, behavioral, and environmental factors that are the true social determinants of health. Social determinants of health, or SDOH, can be grouped into 5 domains and categories. And actually, I know that many of you are probably very familiar with this concept and have done a lot of reading. And there are variations in how different authors choose to categorize these, but this is what we're going to work from today. And really, they all kind of end up meaning the same thing. I'm going to start up here at 1 o'clock on our dial here, and we're going to talk about neighborhood. The neighborhood domain includes housing, transportation, workplace safety, food availability, environmental conditions, and sufficient social services. Moving on down, education speaks to the quality of daycare, of schools and adult education in the community, and literacy and high school graduation rates, along with English proficiency. The social context addresses demographics, social networks and support systems, social cohesion, community safety, criminal justice climate, along with other things. Economic stability really focuses on patients' employment status, their income, and where they rank in the poverty status. And then healthcare access, that speaks to access to high quality, culturally and linguistically appropriate care, health promotion initiatives, and attitudes towards healthcare, and then use of services. It's important to note that while everyone who lives in a community shares exposure to the same SDOH factors, individuals within that community might have varying social needs. So, for example, one member of the community might be homeless, while another living in the same community does have adequate housing, and so that is not an SDOH stressor for that individual. But what we're seeing is that increasingly healthcare systems are trying to assess the specific social needs of their patients, and they're trying to help patients meet those needs. The urgency for SDOH data is particularly strong today as value-based payment models are pressing health systems to raise quality and lower costs. We're all very familiar with that. What we are realizing is that it's the vulnerable patients from an SDOH perspective that are often the most complex and the most costly patients. Fortunately, every facet of the healthcare industry right now is working hard to address social determinants. Indeed, some estimates are that health systems are spending approximately $2.5 billion each year on efforts to tackle SDOH needs. What we know is that understanding and addressing the needs of these vulnerable patients can result in more effective and less costly healthcare across the care continuum. And this is really causing a shift in the payer offerings. And some have estimated that by the year 2023, which is only 2 years from now, that healthcare insurance products are going to look very different. And it could be that as many as 60% of health insurance products will be characterized into two models, either standard or individualized models, which actually accommodate social determinants. So let's talk about vulnerable patients. This is really causing this whole concept of SDOH is causing a shift in focus for care management. What we realize now is that a successful population health program does not focus solely on complex care management from a clinical perspective. Historically, we've always focused on those patients with the most comorbidities, with the most, with the most severe health diagnosis during their admission, but now we really need to look beyond that. The ongoing shift away from fee-for-service towards value-based care incentivizes organizations to actually care for the whole patient and to understand all of the factors, including social determinants of health that are contributing to the individual's health or wellness. This requires understanding where a patient lands on the continuum of wellness and what is contributing to that individual's health or his illness. It's important to treat the whole person, not just the diagnosis, and to target interventions appropriately. And as care managers, we need to make discharge plans that are specific to the individual. A healthcare organization must agree first of all how to define what constitutes their vulnerable patients, and then identify those patients who are the most vulnerable in its population. And then the next step is to target those rising risk patients for care management and for long-term community support. This is how we can prevent readmissions and improve health outcomes. And this quote is from the CEO of Aetna, Mark Bertolini. And although I read this a while ago, it really has resonated with me. He says that the only way to truly disrupt the cost of healthcare is to go into the homes and meet the social determinants that are now driving as much as 60% of life expectancy of Americans. So he claims that your zip code matters more than your genetic code when it comes to determining life expectancy. Pretty interesting. As we've said, an important first step and prioritizing care for vulnerable patients is to understand who those vulnerable patients are. And what you'll see listed here are several ways to identify the vulnerable patients in your organization. So that includes the ICD-10 Z codes, assessment and screening tools by care managers or bedside nurses, primary care provider assessments, utilizing data from your EMR, including demographics and zip codes, and then referrals from frontline nurses. It's really important for care managers in the hospital to receive referrals from bedside nurses so that they can be alerted to potential SDOH needs. So keeping those that care team connected and communicating is really important. Let's talk first about some of the ways that we can identify these vulnerable patients. The SDOH-related Z codes were introduced in 2015, and these are ICD-10 encounter reason codes that are used to document SDOH data. And as is the case with most of the coding, the initial ICD-10 guidelines specified that coding professionals could only report Z codes that were supported by physician documentation. As we know, that's kind of a general rule in HIM coding practices. Well, as a result, what we saw is that many hospitals were unable to utilize these codes because social needs are usually not documented by physicians. Usually, these needs are documented by care managers, discharge planners, social workers, or bedside nurses. The AHA, the American Hospital Association, recognized that this was a problem, and they have worked to increase the utilization of Z codes. In 2018, further clarification was approved, specifying that any member of a person's care team can collect SDOH data during any encounter. This includes the documentation by social workers, community health workers, case managers, patient navigators, and nurses. And this documentation can be in the form of anything from health risk assessments, screening tools, documentation of person-provider interaction, and even individual self-reporting. So that was a big step forward. So now our HIM coders can look at just a wide variety of documentation as they look to assign these Z codes. However, research is showing that these codes are still significantly underutilized. So it's really important to educate staff on the need to screen, document, and code data on patients' SDOH needs. We just think that it's important to encourage your team to ask patients about their SDOH needs. Patients may not know that they should be discussing non-medical issues with their providers, and they may need to be prompted to do that. And actually, there was a survey done not too long ago by Kaiser Permanente that found that an overwhelming majority of respondents really want doctors to ask them about access to meals and safe and stable housing. So these are the Z code categories, and then underneath each of these categories, there are individual ICD-10 codes. Some categories have a couple, some have as many as 15 individual, very specific codes. So it's just very important to be aware of these and to encourage the use of these within your organization. Another important tool in identifying and understanding who our vulnerable patients are screening tools such as SDOH assessment tools. And these tools can decrease the time required for care managers to record patient-related SDOH information. They don't have to be lengthy at all. They can be brief, targeting just those 5 health-related social needs. But the great benefit is that having a screening tool really improves the consistency of the documentation. So you're not relying on narrative notes from various different caregivers. You're collecting the same information from every patient every time. And that's going to give you much more reliable data. These tools can also integrate into the EHR within your organization. And Dana later on will show you how the MoreCare assessment tools are able to pass back and land into the hospital's EHR. And this allows that information to then become part of the medical record, and it streamlines the process of communicating these needs with the rest of the care team, so everyone sees the result of these assessments. And then also, they can be utilized by coders for capturing those Z codes we just spoke about. But it really, really, this last bullet here really speaks to something that's a huge benefit here. It's really important that the information from these assessments can be gathered, can be collated over time, and you can really begin to understand what your patients are experiencing, and you can also look and see how high scores in certain SDOH stressors can correlate to either readmissions or multiple ED visits, or longer lengths of stay when the patients are in the hospital. So it really allows you to kind of start to bring together the social concerns with how patients are performing in your organization, what your outcomes are, I should say. The cool thing is that there are so many screening tools available. I mean, we are just providing here a very short list, but honestly, there is just a wealth of information that's publicly available. These tools are being put out there. They're free for you all to use. The very first one there, PREPARE, is one that you might have heard of. It's an acronym that stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. This is a little bit more focused on outpatient chronic disease management and the primary care provider, but it's a great tool. The second one there is a tool that's been put out by CMS, and we've actually loaded this into our MoreCare solution. It's available to our MoreCare customers. And actually, one of the things that we provide in our solution is the ability to create assessments at any given time, so that you can, if you find an assessment that you feel is appropriate for your organization, you can replicate that. That can be built into your care management system. Also want to point out that there was one here that we identified at the bottom, the WeCare tool, which is targeting specifically pediatrics, which, as we know, those are really different needs there for our peds patients. So again, the benefits of these tools are, first of all, that implementing an SDOH screening tool within a clinical setting can really result in better family and patient engagement. What they found is that talking through the screening tool with a patient and family allows those who are being asked the questions to identify unmet needs and barriers they anticipate, or either that they anticipate or they're going to have, or that they're currently experiencing. And this really allows the patient and the family to feel empowered and engaged with their care team, and as they can prioritize what's important to them. Also, the scores from these screening tools can be set up to automatically trigger referrals or further assessments or follow-up activities to occur. So, it can be a tool that actually generates additional activity specific to how that patient responded to questions. Also, it can be set up so that the results of a survey can automatically enroll patients into appropriate chronic disease management programs that you might have, or into community follow-up programs that you might have. So again, you can kind of harness the strength of these tools. And at the end of the day, discharge planning and readmission management are improved because there's better communication, and we can more appropriately use and follow up on the programs that are available to patients. We can't do all things for every single patient. That doesn't make sense. Doesn't make sense from a cost perspective, from a resource perspective. So what we're trying to do in care management all the time is figure out how to most appropriately target the patients, those patients who need specific programs and resources. And by assessing the SDOH needs, we are much better able to do that. So the next step then is to develop a plan. So rather than developing solutions based on what we believe intuitively is, our needs of our patients, by taking the time and making the effort to collect the SDOH data, it really allows us to better identify the barriers and to work together. Both providers and communities can work together to resolve them. So it's kind of like, what is perceived versus reality. We want to make sure that we're really taking action based on what the true needs of the patient are. So again, the SDOH data can improve care coordination and more appropriate referrals. It can identify those needs, and it can allow us to link patients to these needed resources. These are just a few examples here. And then also important is, to be able to look back in time and look and see patients where we identified a specific need. And then we were able to link those patients up with the appropriate resources. Did that make a difference over time? Are we seeing that our outcomes are changing? Are we seeing that our costs are decreasing? If not, we might need to take a look at what resources we're offering these patients. But having the data allows us to do that. So. Okay, this is a quote from the CEO of the De Beaumont Foundation, which is a foundation that focuses on improving health at the community level by investing in all types of tools and partnerships. This Dr. Castrucci said that when you think about social determinants, those are impacting everyone simultaneously. So it's not about a specific health system. It's not about a specific panel of patients. It's about the community. And that leads us into talking about clinical and community linkages. And these are collaborations between clinical, community, and public health organizations. And these are strategies that improve access to preventative services, such as screening and counseling. They provide access to community level programs and appropriate medical treatments. And what we've shown is that improving access to these types of services really has been shown to reduce and prevent disease in our community. I'm going to share with you an example. And this is from Atrium Health, which is a health system serving patients in North and South Carolina. And their chief community impact officer is Dr. Cole. And at a recent value-based care summit, Dr. Cole shared some experiences from Atrium Health that I wanted to share with you today. After using data analytics to identify patients at high risk of readmission, Atrium decided to look closer at the socioeconomic factors that could contribute to those risks. And what they discovered was that approximately 70% of their high-risk patients were food insecure. And out of that 70%, more than half were eligible for SNAP benefits, but didn't realize that they qualified for assistance. And apparently in North Carolina, the application for nutritional assistance is like 13 pages long and really difficult to complete. So what Atrium did was they assigned a community health worker to walk applicants through the application to ensure that they received the benefits that they were eligible for. The result, on average, these people received $200 more a month in assistance. And what they saw was that the readmission rate for these high-risk patients who received the extra help with their applications and were able to get the money, their readmission rate decreased by 67%. So it not only results in significant cost savings for the healthcare system, but it also positions those community health workers as a valuable resource and an ally for the patients. And it makes sure that those individuals know that Atrium Health is there to support them. That's causing an attitude shift within the community, that goes beyond just dollars and cents. Dr. Cole also shared that Atrium has seen success with its Community Resource Hub. This is a catalog of services that are available nationwide, and they're free. And this quote from Dr. Cole really sums it up. She says, "This is how we are able to answer the question, what do I do next when a patient screens positive for a social need?" Now, a community member can refer himself to services, or a member of our care team can do it, and they can talk back and forth with the service agency. With this Community Resource Hub, we're now able to have digital communication between these entities that enables us to take action if we need to close the loop. And you all might be sitting there thinking, because I know I come from the hospital side for many, many years. I think Dana kind of elaborated on all the years. But what we I can imagine is you're sitting there thinking, well, this sounds great, but how on earth do we get started with that? Well, I'm going to direct you to the AHRQ website. As you know, that's the Agency for Healthcare Research and Quality. That's an amazing organization with just a huge, a wide variety of tools. And they actually have tools for a toolkit for making clinical community linkages. They have resources, they have presentations that people have done. It's really just an amazing site. So I would encourage you all to go there and spend some time studying that. It might help you kind of begin to take those first steps. We also mentioned that we were going to talk to you all about patient engagement strategies. And for this,
Mhm.
I'm going to turn this over to my colleague, Dana.
Thank you, Beth. And you can drive and I will
Okay.
sing.
Okay.
Okay. All right. So patient engagement strategies, of course, that is extremely important. And I love this little phrase here, the concept of the last mile, which is the challenging point between the last thing that happens before fulfillment. And as a documented here, like in selling retail, right before you complete the transaction. Well, in healthcare, the last mile is engaging a patient to buy in and actively participate in their plans of care. And this really is a big thing. I read an article last week where this hospital had put together a very nice program, set up all these things for their patients, but nobody was actually utilizing them. And without getting patient engagements, you're pretty much dead in the water. So, a couple of strategies to encourage active patient participation. I'm going to talk about one is communicate early and often. We already know that we do discharge planning on admission. Well, there's an opportunity to include the SDOH conversation during that time. Okay, even when the patient comes in the ED, let's get the nurses engaged. Let's get the physicians engaged. So that's so important. So you're going to keep communicating that. You want to keep the information very simple, and which includes knowing what we can do to help. We don't want to, throw out all these things. Oh, you need this, this, and this, but what can we do? So keep the information very, very simple and be as detailed as possible to try to get to what is the root cause of what's going on with my patient. We also want to ensure that everyone is on the same page, including the patient support system. We always forget about them, the caregivers that are helping and assisting with these patients. Get them involved and to talk about how we're trying to help them help their patient, which of course helps us in the end. The next one is get involved in helping the patient set their goals. Again, help patients understand the benefits of staying engaged, less hospital visits, especially in this world of COVID right now, less clinic visits. You can really stay engaged and reach out to your navigator or to the nurse hotline, and that will really help you stay involved with your goals. And then, of course, last but not least, follow up again and again and again. If you have an outpatient navigator program or chronic care program, make SDOH part of that. And then during that time, you can have these touch bases. You can set appointments for monthly or quarterly checks, or just be the contact person when the patient needs one. And just a little tidbit here, I also read that, and we probably know this, that one-on-one human interaction, in addition to digital engagement, has been proven to increase the active rate of your patients of more than 70%. So again, if you're able to talk with the patient one-on-one or give them a phone call, get that relationship building, just how in sales, and then you might have better outcomes with that engagement strategy. Okay, Beth, next slide. Okay, now with us, More Care, we incorporate the SDOH into the care management across the continuum. Okay, and that's one of the things when we talked about, what was our next presentation going to be on? We really realized that we were able to help at least get the conversation started, at least help get some of the patients started using some of that, as I mentioned before, the low-hanging fruit. So so the first one, of course, is risk scores provide visual alerts for case managers. So as you assess your patients, visual alerts enable clarification of our SDOH risks situations with our patients. And I'm a very visual person, so seeing that right on my work list is so important. How can I help? The next one, enable precise and targeted intervention. So in other words, what drives your SDOH scores? What are the scores telling us? Well, we have automated triggers that put those scores into actionable items. Again, those visual clues out there. Okay. Discharge planning and readmission management are improved. And of course, as you start to reach out and include the SDOH into your care program, that is pretty much just a given because you have provided a link for them to reach out to community-based services, to reach out to your navigator, and then of course that will lessen readmissions as well as lessen the problem with discharge planning, trying to get everybody together on one page. It really allows you to really focus on your SDOH and the programs that the patient is in. And lastly, analysis, trying to identify via a report or dashboard, are things working? What are the defined resources that you're looking at on a daily basis? How many times are you searching for transportation? How many times are you searching for other community resources? By looking at your process metrics, you can really tell where the intensity of your touch is really needed or if what you're doing isn't working. Beth mentioned about all the different assessments. I've included a couple in my presentation today, but in real life, as I'm using these, if they're not working, then I can include in another type of assessment. Okay. All right, so it is time for a poll. You guys, please participate. How are you currently assessing your patient for SDOH needs? Z codes, assessments, electronic or automated tool, all the above or none of the above? I'll give you guys a few minutes. And I think, Beth, if you click on, I don't know if Andrea is on, make sure we clicked on the button so that they can actually take the poll. And we'll give it a few minutes. Okay. Did we finish up, Beth? Can you tell if people are filling out?
I cannot. I think Andrea is managing that. So
yes, we have about 74% of you guys have responded. So we'll give it another second there.
Wonderful.
And now
wonderful.
10 seconds here.
Mm-hmm. Need to have a little music going while people are filling this out,
like the Jeopardy music.
Okay, I'll close this poll here in 3, 2, 1.
Thank you.
Okay. And so just real quick, I don't know, Andrea, if you're able to see, is there anybody that that's not using any of the above? I'm just real curious real quick.
Surprisingly, yes, there's 1%. Fortunately, a lot of people, the 63% are using assessments.
Oh, wonderful, wonderful. Right. Okay, that's good to hear. But we really want to get you guys, get one of the main low-hanging fruits are those Z codes. So really start focusing on those, and I'll show you how that works out in my workflow as well. Okay, to our case study, Mrs. Adams. So patients admitted, so what we know, these are things we always do as case managers. Patient has a history of diabetes, hypertension. Lately, she have had multiple visits for hypoglycemia. She has a PCP. She's compliant with her care plan and meds. Everything seems to be fine. So we've just been, every time she comes in, we just, hey, here you go. Let's talk to you. She says she's taking everything fine. And then she ends up back into either for a quick ED visit, an observation visit, or an inpatient visit. Okay, now, once we incorporated SDOH into our workflow, let's see what we found out. Her husband is deceased, passed away about 8 months ago. She has grown children that are out of the house and are actually in a different state. Her aging parents recently moved in with her as opposed to going to a SNF, so she's caring for them. Financial limitations. She receives a small pension from her husband because she was a homemaker. Okay. She has a car, car works fine, but money for gas and maintenance is a challenge for her. So she doesn't really drive it that much. So transportation is kind of a problem, but we wouldn't have really picked up on that if we hadn't really dived deep. And then she admits that sometimes money doesn't go as far as she would like it to go before the next check. So in her just thought process, she would just forego a couple of meals so that she has enough money to stretch. Now, spoiler alert, what we identified after this particular visit and following up as a case manager or an outpatient case manager or navigator, we realized that she didn't understand that skipping those meals, even though she might, drink some orange juice or have that peppermint, was actually causing her hypoglycemia, was actually causing her to have these dizzy spells and all that to come back into hospital. And she just didn't put those two together. Okay. So what needs to be addressed? Food insecurity. How can we help her with that? Of course, trying to find some food banks, Meals on Wheels. And even Beth mentioned earlier about that SNAP program that, what was it? I think that's it, 70 people, 70% didn't even realize that they were eligible for. She was
That's right.
eligible for SNAP, but she never thought about it. She's a proud woman and just figured she would just, keep doing what she's doing. Transportation needs. Yes, she has a car, but there's free services out there that will take her parents to their doctor appointments. So that'll lessen her driving, getting meals delivered, things like that. And then also resources to assist with elderly parents, adult daycare that's free, that provides lunch for the parents. So there's so much out there, but you have to ask the right questions to be able to help the patients. And this is all still new. We're still trying to figure out how do we take care of these patients. But first, we have to understand who are they, what are they, and what do they need. Okay. Next slide. So I'm going to jump into our More Care solution. It's going to be very brief, but we're going to talk about how we use some of the tools in our system to identify the patients, including those Z codes, which is, no work that I'm doing at all as a case manager. We're going to talk about the screening using some of the More Care SDOH assessments. Like Beth mentioned, I'm using the Prepare, another one from CMS. And then we're going to talk about how you can try to keep the patient engaged if you have an outpatient care management program. I know a lot of us don't have enough warm bodies, but there are some things maybe we can do, even where it comes back to after the patient goes home. Document on your chart to do a follow-up call about 2 weeks later to say, hey, how is that list working out that I gave you for transportation and this and that? Okay, because the time that you take will lessen that readmission in the future, lessen resources that you have to spend. Okay, all right, so now I am going to share my screen and go into a quick presentation. So let me see here. And I do not see, I might have to have Andrea, you to do something to make sure that I am able, oh, there it is. Now I'm able to share. Okay. So let me go to screen 3. And Beth, if you could just verify that you see my
Yes.
screen. Okay,
Yes, ma'am.
excellent.
I see. Mhm.
Okay, here's our splash screen. Again, this is More Care. And one thing I want to bring your attention to is just this first quadrant right here, which is my work list. And this is where my patients are automatically placed on my work list or my to-do list for me to do my normal case management work. So let's go ahead and click on that, and that'll bring us right into my review work list. Now, one thing I want to bring your attention to, you see the screen is very, very colorful because I have a lot of visual alerts that helps me assess my patient, not only clinically, but socially as well, or more holistically. Okay, so here you can see that I have one of my patients here. In the middle, I have the different tasks that I need to do. So you might see a patient on here more than once, but based on the rules that we have in our system, the rules identify for me not only an admission review, but also it puts out there a discharge planning review, because those are two different things that I want to be able to do. Sometimes it might be just me, and sometimes I might have help from a social worker as well. Okay, we have our chief complaints. We can see kind of what's going on. Another visual clue is that I'm using conditional formatting here to identify when my patient does not have a PCP. So that's something else I can kind of hone in on a little bit. Everybody needs to have a PCP. Otherwise, they're probably using the emergency room as their PCP. I have, of course, my current length of stay. I have the insurances. And then over here, I have some neat things. I have a risk for readmission score. I have this set up so that if it's over 10, I want it to turn red. This means this patient really is at risk for readmission. So what do we need to do about that? I have an SDOH score for my discharge planning review, and we'll talk about that in just a minute. And then I have discharge notes here, just quick little notes to let me know kind of what's going on. And right here, home with referral to community services. So not necessarily home health, but just with a list of different community services that can help my patient. All right, so here's Miss Janie Adams down here at the bottom. And so when we think about how are we identifying these patients, again, everybody gets a discharge plan and review, so include that assessment. But in this case, I thought that we will start with readmissions. So I took the readmission rule that we have and I just add a little twist to it. I documented that if the patient is a readmission with one of those Z codes that's been coded by the coder that Beth showed on her screen, then identify that for me and give it a special type of task. So I can know not only is this just a readmission, this is a readmission where we identified SDOH issues via the coding. So that's those Z codes, guys. Again, low hanging fruit. Once I come in medical necessity, and this is where if you are doing UR as part of your case management process, you will come to medical necessity review, do your INAQUAL or your MCG. But here under assessments is where I added an SDOH profile, okay, or screening. So here, anytime that we have readmissions at my hospital, we have the case managers document a readmission tool to determine what's the root cause readmission, but I also included an SDOH screening tool. If you don't want to do this here, then I also have one in discharge planning. So you can have as many specialized question and answers or assessments as you want. Again, try different ones. So in my process, if the UR person doesn't do it, then I actually make it part of my discharge plan in MCCM, where I'm also doing some additional assessments as well. Okay, so once I come to my discharge planning review, I'm going to click on assessments here. And once I click on this, I'm going to open this up a little bit so you can see all the various assessments that I have here in this area. So the first one I have is my COVID-19 assessment. So I can begin to fill this out. Under screening assessments, this is where I have my modified LACE assessment. And here is my CMS screening tool. Now, this is one that I added recently. This is one that is put out by CMS, and the HRSN stands for Health Related Social Screening Tool for Medicare and Medicaid. And what this does, it allows you to find patients that are in need of maybe 5 core domains that community service can help with: housing and stability, food insecurity, transportation, and utility help. So again, this is just one of many. So as I go through here and go through this screening tool, I have added scoring in here, and this is something that you can do as well, add scoring. The answers can be radio button, drop down, free text, and it's very easy to fill out. So what's your living situation today? And of course, she's fine. She has a steady place to live, no problem. Are you having any problems with anything within your house? Lack of heat, mold? She's like, no, I'm fine. Okay, food. Within the last 12 months, were you worried that food would run out before you got money to buy more? And the fact somebody's asking her, it allows her to think, well, yeah, sometimes true or often true. So now we're starting to get to the root cause, and that's a score of 3. The past 12 months, have you bought food that just didn't last until you got more money? And I'll say often true again. Transportation. So then as she starts, we're asking her these questions, she's getting a little bit more frank with us. Utilities. You say, well, everything's okay with that. And then also this screening tool includes, but she doesn't have any issues with these at all, but there are a lot of safety ones here that we want to be concerned about. Are you concerned about maybe abuse in your home? Does people scream at you? So you can include those, or you can exclude those if you don't want to answer or ask those type of questions. Financial strain, we have a question on that. And I'll say it's somewhat hard. And family support here. Right here, for any reason, do you need help with day-to-day activities? And she's like, well, I don't, but my parents do. So I'll say I could use a little bit more help. So again, helping us walk the patient through these answers face to face. Our system is available even to ask these questions on an iPad. So I can sit right at my patient's bedside and ask these more sensitive questions. So once I save this, I'm going to show you what happens. It automatically pops up several triggers. This one right here, I have it set, so I have to actually set it as I have to actually reaffirm this to make sure this is what I really want. So do I want to generate a concern? And this is actually going to schedule an assessment for my outpatient manager. And I'm going to say, you bet, because based on what I was assessing, I think it's going to be a problem. So total actions that were identified. Let's look at this here. It created an alert to say that there's a food insecurity. It also created an alert that there's a transportation insecurity, and it sent my case manager a message, or my outpatient case manager, a message to say that I've scheduled an assessment, a peer assessment for you to do because I think this patient really needs one. Okay, so again, by me just filling out this assessment, it actually turned the scores into visual alerts. Okay, so I'm going to close this. So right here, I have this high alert that's showing here. And if I click on this, it's going to automatically show, again, what those scores meant. So again, I have a food insecurity document for my patient, a transportation, and I can add additional notes in here if I would like. But the nice thing about this is that this stays on the patient, this stays with the patient. So no matter how many times the patient comes in, and right down here, these alerts are going to be there until we expire them. And anybody that's utilizing MCCM can then look at these, whether it's a social worker, a UR person, a case manager. And the nice thing about this is that once I fill out that assessment, that information is exported back to the EMR. So now even the physician can get involved and say, oh, wow, I didn't know that the patient was having some issues with this. So you get everybody involved in that. So I just love how some of those visual clues work. Even here for my patient here, 17 SDOA score, risk for readmission score. So these are actionable things that I can really do something with. So now let's go right back to Janie here. So now once I completed my assessment, I can then begin to say, okay, what do I need to do for my patient? So this patient is definitely going to need some resources. So I'm going to put here home with referral to community resources. Again, this is going to show right on my work list. Anticipated discharge date, according to physicians, she's doing okay. So it'll probably be tomorrow. So we're going to give it one more date here. Actually, I'll open up my calendar. Oops. And give it on the 16th. Okay. And also, what is the planned discharge date? Well, it's pretty much the same thing. According to the physician, the patient should be going home tomorrow. So I'm going to go ahead and save this information. Oh, hit this one more time here on the 16th. And there we go. So save this particular information. So now what do I need to do? The patient doesn't need home health or anything like that, but I do need to find some resources. So now let's go over to our provider networking area where we can actually look for some of those resources. And I love how the topic list here allows me to go where I need to go in just a matter of a click, and it takes my patient with me. So now I'm leaving the discharge planning area and going right to the provider network, where now I can look for those resources for my patient. It includes the expected discharge date that I included in my discharge planning area. And now it's asking me what service type am I looking for. So here you can see that I have several service types, and this is powered by one of our provider research search engines that identifies various areas underneath these categories. So if you need community resources or diabetes education, aging and disability resource center, which would be great for Ms. Adams with her parents, okay, home health, psychiatric, pharmacy, outpatient. So there's a lot of different things here, but right now we're going to look for food banks, okay? And let's see what we get there. So I have my food banks, and now once I hit save, I'm going to search here for some food banks. And I'm actually in Delaware, so I'm going to choose Delaware here. I don't want any CMS, star rating restrictions, and I want a small radius here. So I'm going to go ahead and click on that, and immediately it pulled up for me 2 resources that's going to help with those food services that are within her area. Okay, so probably they do deliver. So I'm going to select all of these, and these are now going to be on my active list. So now you can see under active providers, I have 2 providers. At this point, I could print this out and provide this for my patient. And also I can look for additional providers as well. So let's go back to review and let's see what else we might have. So I'm going to click on add new again. And maybe I want to look for community resources. And another nice thing about this is that if you don't want to do a full search, you can include your own individual community resources that you use all the time. So I'm going to take out this state again here and put in my Delaware, and then I'm going to click this drop down here. And I already have some community resources that we have cultivated within our community. I have crisis intervention services. So again, if you don't want to use the whole big search area, create your own list. And once you choose that and hit the plus sign, then you see that you can have some additional providers there. So under community resources, I have 4 more. So again, being able to print this out, and I actually have one for my other patient that I did. So this is what I'll provide for my other patient. And I'll print one out as well for Miss Adams. These are some transportation services types that she can then call on and utilize if she needs to help with that. Okay, so again, utilizing a great search engine to identify those community resources, transportation, food banks, that those again are low-hanging fruits that you can see. A lot of these are actually free services. So you're not really doing a whole lot more, especially if you don't have the bodies. Okay. Now, for those of you who do have the bodies to have an outpatient navigation program or a chronic care program, I recommend using that to stay engaged or to keep that engagement with the patient. Now, I can tell you when the patient, again, when they come back into the hospital immediately, when you start seeing these alerts, you can start that engagement right away. Hey, Miss Adams, I noticed the last time you were here, you had food insecurity. How's that working for you? Or how's the transportation list that we gave you? Is that doing better? So that allows you to keep engaged. However, if you do have an outpatient program, I'm going to take you over here to our continuum work list here. This works extremely well. So one of the things that I can't show is that based on those Z codes, I was automatically able to run a rule that will then send a message or create an assessment on the continuum work list for that continuum or that nurse case manager. As well as one of the things that I did is that I also sent her a concern. So when I filled out that documentation, that assessment, look what happens. This sent an email to my outpatient or my nurse navigator to say that, please assess this patient for SDO needs. A prepare assessment has been auto-scheduled for this patient. Thank you. So this is giving my outpatient case manager heads up that I've already scheduled something that's on her work list. And then we're keeping that communication really, really tight with that. And here it is for one of my patients here. So PREPARE is another assessment, and it stands for Protocol for Responding to and Assessing Patients' Assess, Risks, and Experiences. I like this as an outpatient follow-up because it gets a little bit deeper. And as you can see here, I love having this attached to some of my chronic care programs. So I manage that diabetes management as well as the chronic care management as an outpatient. But you see how I was able to include that prepared document right in here so that we're able to utilize to assess. So let's go ahead and look at my other patient here. Just take a look at this. So I'm going to click on prepare. Oh, and over here you can see when they're scheduled. So on 10/6, I'm going to call Ms. Garcia and we're going to do the prepare Hall Herman. So you can actually schedule these and it'll alert you when it's time to contact the patient. Actually, I need to reach out to this patient today. So we'll click on this one. So once I come in here, I have a little note here that I can click on. This again can explain what the Prepare is. This is an area here that I love because I can make it nice and big, because since I am a little older than 50 or closer to 60 now, I need that to be able to see a little bit about that. But here is my assessment. So now I can go in here and begin to do this assessment. You can see it's a little bit more detailed. Um, what language are you most comfortably spending or speaking? Are you worried about losing your housing? What's the highest level of high school? So again, this is the Prepare assessments. If this one isn't working for you, then you can definitely include another assessments. You can again have scoring and triggers on these, and you can schedule follow-up visits or calls with your patient right from here. And this is one of my favorite ones as well, because I might need to follow up with a phone call, especially when we talk about the caregivers. Let's call the caregiver and say, hey, can you be included in this assessment that we want to do? You put in your scheduled date and time, and then it will now be on your work list or on your to-do list to be able to manage that. Okay, so I just wanted to go over just a couple of quick things here that you're able to do with our system, and hopefully if you can't do it with yours, you can definitely do it with ours. But we feel confident that these are the low-hanging fruits and things that you guys can do along with your assessment screenings. And I'm so glad you guys are using those. But really grab those Z codes and start letting the coders help you out with that, because again, once it's documented in the medical record by any clinician or licensed social worker, then we're able to code from that, and then we can get the ball rolling. Okay. All right, Beth. So you can go ahead and take the screen back now, or either I can
Thank
stop
you.
sharing. You're welcome.
Thanks so much, Dana. I appreciate
Mhm.
it. That was a great overview. I think you have to
Gee.
release and
Okay.
then
I
I
think
can
I just
share.
did.
Thank you.
Hmm.
Okay, great. Can you see, oops, sorry. There.
Not yet.
Can you see my screen?
Yes, there it is.
Okay, great. All right. Well, in summary, and I know we're getting close to the end of our time, so we have just to wrap up. The goal here is to, as you know, the whole goal in capturing and utilizing SDOH data is to improve health, lower cost, and advance health equity. And we spoke earlier about the fact that the way to do that is to identify those vulnerable patients and then target the utilization of scarce resources. I don't think there's anyone in healthcare right now who feels that we have enough resources to meet all the needs of all the patients. And so what's really important is to find the right treatments in the right setting to the right patients at the right time. That's really the key here. And the
Yes.
SDOH data can really help target those interventions. One last quote here, and this is by Dr. Nicholson, who's Chief Medical Officer at Care Allies, which is a consulting firm that works and helps physician practices make adjustments and adapt to value-based care. And I thought that this was really a great quote because he recognizes that customers, his physician practices or hospitals are kind of overwhelmed by this whole thing. And he says, but now that we're here, start where you are. Start small, but take that first step and realize that anything you do will need to be expanded on, but you have to start making a dent in this problem right away. So it's just, start. All right. Can we answer any questions? I don't know if we've had any questions from the group or if anybody at this point in time has some questions for us.
Well, I think that we
Andrea?
have one
Okay.
from a user
Okay.
that they're asking, what is the case manager's average patient load? And that's a very good question. We've seen a lot. A lot of times, if you have a case manager that is doing the UR and the case management, then their loads are a little less. And I've seen them as low as 25. Back when I did case management, I did not do the UR part. So I had a 40 patient caseload. So it just varies depending on how many tasks that you're doing or you're allowing for that case manager to do. But I can tell you, by having a system that has your workload right there in front of you, whether it is a discharge planning review you need to do, a denials review, or UR review, that does help streamline it a little bit more. But again, it just depends on what all your case manager is doing with underneath their license or underneath their umbrella. Okay.
All right.
And
Thank
I
you.
think that that's all that we have right now. Somebody did ask, are we going to have this recorded? And yes, the recording will be available. We'll send that in a follow-up email, and it'll be available on our More Care blog. Okay.
Yes. And please do check out our Knowledge Hub at our website, which is www.morecarellc.com. We'd love to have you all check. You can also reach out to us there. Also, here is my information. I would love to hear from you all. If you reference this webinar, we'll be sure to get either Dana or myself to get back in touch with you. So please don't be
Absolutely.
shy. We would love to hear from you and talk to you more about how our solutions might be able to assist you in this really, really important facet of
That's not
care
going away.
management. That's right. Absolutely. So from Dana and myself and everybody at More Care, we just want to say thank you all so much and keep fighting the good fight out there and have a great day. Bye-bye.
All right. Bye-bye.